Welcome everyone to day 2, part 2 of the Carer Knowledge Exchange Research Incubator for 2023. For those of you who were with us this morning, welcome back. And for those of you who are just joining us now, I hope you'll enjoy the session very much. The session is Making Connections, Exploring Carer Health and Wellbeing. Before I begin, can I just remind people that this session is being recorded so that we can share the knowledge after the event. I'd like to begin by introducing myself. I'm Professor Carol Mills. I'm the Director of the Institute for Public Policy and Governance at UTS, and we are a very proud partner with Carers New South Wales and with support from DCJ for this really important carer initiative. I'd like to begin by paying my respects to traditional custodians of the land from which I am presenting today. I am on the land of the Gadigal people of the Eora Nation. And I extend those respects to the lands where all our panellists and participants are located today. I acknowledge the elders past and present and extend that respect to all Aboriginal people, including any Aboriginal people joining us today. As many of you know, this year's Carers Research Incubator was delivered over 3 days, hosted jointly by, as I said, by Carers New South Wales and ourselves at UTS. Our opening session today covered a number of really important issues to do with carer wellbeing and really interesting research about the way in which, I guess, both carers and people who are being cared for need to come together and work with service providers and support really constructive ways of supporting carers in their very, very diverse roles. The focus for us is very much on evidence-based care and wellbeing initiatives, and our first session, as I said, was very much about service focus. This afternoon's will focus on connectedness and wellbeing, and we'll have a concurrent panel session on hidden carers and carer diversity also taking place, and that will link in at around 4:40 p.m. today. Following the event, we will close this afternoon with an online workshop focused on measuring carer wellbeing in research and in practice. This week's Research Incubator delves deeper into the theme of health and wellbeing, the focus of the Carer Knowledge Exchange events over the last 12 months. And it further examines research, practice and lived experience perspectives on this important topic. One of the things we find most rewarding is actually bringing those three perspectives together, bringing together the researchers, the practitioners and people with lived experience who can really learn from one another and share their experiences in a way that we feel can help both them, but help other carers right across the country. Our session today on social connectedness and carer wellbeing is in a workshop format. It's being hosted by Associate Professor Hugh Bainbridge, who is a member of the Carer Knowledge Exchange Research Advisory Group. We'll hear from 3 panellists, followed by a group work in breakout rooms. And after this, as I said, we'll connect back in with a representative from the concurrent symposium on carer diversity and sum up what we have learned and heard today. I'd like to now hand over to Hugh, and if this afternoon is as good as it was earlier today, we're in for a very rewarding session. Thank you, Hugh.
Good afternoon, everyone. My name is Hugh Bainbridge. I'm based at University of New South Wales and really honoured to be able to chair what is an extremely important session today. And I think we'd all understand and appreciate that wellbeing and social connectedness is central to the experience of care. I've had a really valuable relationship with Carers New South Wales, which I'm just going to sort of draw on as I think about this session. It's extended over 10 years, and certainly a lot of the work that I have done with Carers New South Wales is centred on that idea of overall health, wellbeing, physical and mental, and the connections that people make to participating in lots of aspects of their life, care, work, social, etc. I'm currently the chair of the Research Advisory Group, and again, that's been I think a wonderful opportunity just to think about how things that we do in the more academic sphere of the world can have real world value. And certainly the Research Advisory Group has a strong philosophy that we can help to shape some of the conversations and maybe some of the things that can be done to assist with the experience of care. But we can only do that if we also have a proper deep engagement with people who have lived experience of providing that care. And so having a forum like today and having 3 speakers to help us guide us through these topics, I think is a wonderful opportunity for everyone to come together. The first presentation today, I'm just going to introduce Lynn Covington-Dowd, and she'll be talking a bit about the experience of perhaps a group that can get overlooked in some of the conversations that are had about caring, and specifically to consider some of the subtleties of men's experience of caring and how we might better engage with that topic as it relates to health, well-being and social connectedness. So without too much further ado, I'd like to pass it across to our first speaker, and to Lynn, the floor is yours.
All right, thank you very much, Hugh, for that lovely introduction. So I'm from Western Sydney University. I'm going to basically give you a little bit of a synopsis of the work that I did for my PhD around older husband carers, men who particularly were caring for wives with dementia. So without further ado, I'll go on to the next slide. So just as way of a little bit of introduction to the topic, men are certainly living a lot longer, and they tend to care for wives in older age as well. So they come into caring a lot later, but because they're living a lot longer, they're increasing in numbers as well. In the literature, there's a lot, thankfully, a lot of research about carers. And a lot of it, well, not unfortunately, because women do dominate caregiving, so a lot of it's about women. But in groups where in samples where the men are included, often we sort of get this kind of homogenous view of how men engage with caregiving or even help seeking and support. And linked to that is the idea then that men resist or delay help seeking with caregiving, which has consequences for their health and well-being. So my study then was a qualitative inquiry, and I'm specifically looking at how aspects of identity, such as class, age, generation, and gender, inform the way men engage in informal and informal caregiving support networks. So it included 10, the sample was 10 primary carers. All their wives, they were caring for wives with dementia. They were all living in New South Wales, and they were all aged between 60 and 86 years. The data was collected through semi-structured interviews and photo elicitation, and it was thematically analysed. Theoretical framework was intersectionality, but I think you can have a look at that detail later, so we'll move on to the next slide. So let's begin then by talking a little bit about how these men establish and engage with their informal support networks. So firstly, there was particularly an attempt by middle-class men to ready their informal support networks. So once their wives had been diagnosed, they often took the decision to publicly announce this news through a Christmas letter to family and close friends. But it was also a way of alerting their networks both about their wives' diagnosis, but also about any potential help that the men themselves might need, as Colin sort of illustrates in this quote here. For working class men, unfortunately, they had very limited opportunity to alert their networks because they were more often trying to still get a diagnosis. But they did have the benefit of close-knit family and friends within their proximity of their rural locations where they lived. And this was something that middle-class men didn't enjoy, because often middle-class men living in rural areas had moved there as part of their retirements. So they were quite isolated from family, extended family and adult children, as Len sort of talks about here. So then moving on then to what might be some of the other barriers to engaging with their informal support networks. So the first thing to look at is this idea of self-sufficiency. And this sort of manifests as a reluctance to ask for help. So asking for help is really difficult for these older men because it runs counter to this idea of self-sufficiency and independence that's embedded in their identity as men. So Colin, for example, having readied his social network, then explains that he hopes he's not really going to have to ask for help. He hopes that others are going to see what is needed to be done and offer. Another way that another barrier to engaging with informal support was around it's a similar theme around autonomy and control, but it was autonomy and control is particularly strong amongst older men of the sample, so men of the silent generation, and this shaped their engagement with their informal and formal support networks. So Pete's way of maintaining autonomy is to position himself as a carer expert. And he maintains control of his wife's care even when he goes away, and that results in him leaving sort of he was thinking of leaving a few notes, but he ends up writing a 4-page document. And I guess the final thing to consider as perhaps a barrier for men is that they themselves, although that they were quite proficient and quite proud of their own caregiving, they often had very gendered expectations of the help that their informal network should provide. So we have the contrast here between Colin, who's saying he doesn't want to worry his sons with what's happening and things like that. But then we have, Phil's quite clear expectations of support that he feels he should be getting from his daughter. I mean, that's not to say that other male friends or people in their social networks didn't provide support, but this was often in instrumental ways. So it's shaped by their identities as men, and it was valued and recognized by the men. So examples might be, helping with some home maintenance jobs and things like that. But for care and support or emotional support, the men invariably turn to the women, the daughters, sisters, and female friends in their social networks. So moving on a bit now to look at some of the ways in which men engage with their formal networks in some of the engaged services to help support their caregiving. So the first thing is really some of the enablers. The first thing is know-how. So middle-class men in particular have what we call cultural capital. So they have a lot of know-how about how to navigate quite complex bureaucracies, the health and care systems, which they gained from their middle-class professions. So Phil, for example, here is drawing on skills he developed in various sales roles. He's able to navigate the carer support system because he's noted down the name of everyone he's spoken to and their role, and he's built up a fairly clear picture of how the system functions. So when he needs respite care, he not only knows what's needed, but he knows who to contact to get it. The other enabler is social capital, and it's sort of linked to the first in a way. So the middle-class men often had expertise within their informal social networks that enabled their access to health and caregiving. So, for example, the early diagnosis of one wife was attributed to the fact that there was a family member who was a psychologist, and she'd picked up their symptoms quite early on. David, as a working class man, though, has more limited social capital. But his rural location, his membership of the Freemasons helped to provide it for him. So in a rural town where everybody knows everybody, a fellow lodge member has the cultural capital, the knowledge to recognize what the issues are, and also to provide the contact details of someone that can help David access that support. So what then might be some of the barriers to formal support then? So the first one, I think, is the similar theme to what we had with informal support. It's this idea of self-sufficiency. But I should point out that it's also a very important aspect of masculine identity, which is really strengthened in working class men. And it's illustrated here by David. So men like him have been raised to be practical, so they can almost turn their hand to anything, including, feminized tasks such as cooking, cleaning, and even knitting. But this self-sufficiency also acts as a barrier to seeking formal support, as it denotes this kind of loss of autonomy and independence. So working class men find it both more difficult to navigate social care systems because they lack cultural capital, but then because of their self-sufficiency, they also resist actually engaging with them as well. So it's a bit of a double barrier for them. For many middle-class men who lacked these practical skills of the working class men, they have what we'd call economic capital. They had resources. So, for example, we've got Sam here, who has, he pays for help with his cleaning in his garden. they've used this quite differently to services that are provided by the state, apart from that, he doesn't need help with anything. And he's able to maintain his independence through those resources that are under his control. And when we come back again to autonomy and control, so Pete, as a middle-class man, has successfully navigated carer support services, but then he decides he doesn't want them. He turns it down. And he says, it's because I don't want people wandering in and out of the place. But for older and more frail men like Pete and Sam, of the silent generation, self-sufficiency and independence are even more strongly embedded in their masculine identities. So these men were both child evacuees in Britain during the war, and they talked about how they learned to stand on their own 2 feet and develop quite stiff characteristics. And this is manifest in their autonomy and control. They only really engage with informal and formal support, over which they have significant control. So in that sense, it acts as a barrier as well. So moving more on to emotional support then, which I think is a really important part of caregiving, caregivers' well-being. So emotional autonomy is quite central to older men's identity. So we have to remember that these men were socialized to hide their feelings, as Colin's photograph and excerpt illustrates. He believes in some cover-up. That's essentially what he's saying. But there are some subtle differences between the men. So, for example, middle-class men who had had service sector careers where emotional labour is required, fostered and valued were much more adept at emotion work, and they were therefore much more likely to benefit from carer support groups. They're able to clearly articulate their emotions and appropriately respond to the emotions of others. However, their participation is always in tension with their identity as men. So some men have set up their own carer groups, like Andrew here, where there's more emphasis on shared activities rather than emotion talk. When emotional support is needed, it's often in ways that are individual and confidential, as this enables emotional disclosure without compromising masculine identity. So I'm probably confused you with all these different people that I've talked about and all the different barriers and enablers. So to sum it up a bit, for middle-class men then, I tended to find that their caregiving was characterised by this strategic adaptability. So they really take a very strategic view to caregiving, and they do this firstly by readying their informal networks, by seeking information and resources that they can put into place for the future, and by learning new things. So they don't have great practical skills like working class men, but they have the know-how to learn new skills. And they often felt quite proud of the skills that they had acquired. They also have what we call social and cultural capital. So they have know-how and they know people that can facilitate their access to complex health and care system support. And within their social networks, they have access to expertise, which again facilitates accesses to services and resources. They have communication and emotion work skills developed in professional careers, enabling them to benefit from models of support requiring self-disclosure, similar to carer groups. But as I mentioned earlier, this is always in tension with their masculine selves. So they prefer emotional support to be provided in confidential and anonymous settings. To sum it up, these men have social and cultural capital to take advantage of consumer-directed care frameworks that respond to their service equipment, consumer care product needs and personal needs. So looking then, comparing that with how working class men do their help seeking. So working class men's caregiving is characterized much more by a functional flexibility rather than a strategic adaptability. They draw on their functional and practical skills to manage caregiving, and they tend to deal with problems as they arise through more of a trial and error approach. However, They often lack cultural capital, the know-how to navigate complex health and care systems. They find it overwhelming. They don't even know where to start. And they also have much more limited social capital. They're less likely to have people within their informal social networks that can provide support and expertise and access to resources. But this disadvantage is attenuated in rural and remote areas where there are flatter class structures and where there's more access to people of different backgrounds and groups. And it's also attenuated by the proximity of their families who live nearby, which is often not the case for middle-class men living in rural areas. So working class masculinities incorporating notions of self-sufficiency and emotional autonomy are a barrier to seeking emotional support for working class men. Carer groups and talk therapies based on emotional work and public self-disclosure are also barriers to men's participation, as emotional labour and the skills to communicate complex emotions have not been valued in their working class professions and therefore are underdeveloped and also undervalued in this group of men. So to bring it all together then, I've we end up with a model of caregiving practice and help seeking that looks something like this. We have these four competing tensions. We have strategic versus functional, and we have adaptability versus flexibility. So middle-class men are positioned in this upper left quadrant, and we position working-class men in this lower right quadrant. I do want to point out that these are not hard boundaries. Working-class men can sometimes be strategic and adaptable, and middle-class men can engage in functional, flexible practices from time to time. However, the model illustrates the way in which identity shapes both practice and help seeking. Their caregiving and help seeking is informed by their experiences as children, growing up in working class and middle class families in the 30s, 40s, and 50s, and the class-based skills and practices that they've developed in those environments and professions that they've since worked and lived in. So I've come up with a few recommendations, and which hopefully will help with the discussion later. But exploring how identity informs men's caregiving and help-seeking practice appears to suggest then that we need quite differentiated strategies just to reach out and support caregiving men, or particularly older men, should I say. So firstly, I guess to improve the agency or capacity of working class men to access health and care resources, we really need to simplify the system, but I don't really see it that has been an easy thing to achieve. So perhaps what we need to think about is a greater role for community groups and organisations that are already supporting retired men. So resources need to be made available to these men in environments where they feel valued and understood, because that helps to normalise help seeking and counter these strong feelings of self-sufficiency. Oh, sorry. Also, one of the disadvantages for the older middle class men of their strategic approach to caregiving is the fact that they're planning for the future and accessing information as they do means that they're much more aware and therefore much more fearful of what is to come. One of my carers, for example, talked at length about cold winds of change and his anxiety about where everything was heading. So strategies are needed to ensure that information about dementia is accompanied with access to appropriate mental health support. And then also, self-disclosure and acknowledgement of vulnerability are antithetical to masculine identity, particularly in older men. Men value emotionally relaxed environments. So in this sense, to create a relaxed environment requires a different sort of focus, perhaps more of a focus on hobbies and interests and groups that are self-directed by the men, with a role for organisations such as Carers New South Wales in connecting men with each other. In this way, men can come together to build trusting relationships with each other and with the organisation so that when help is needed, the men have a ready network of informal and formal contacts that they can approach for help and guidance. And lastly, men as caregivers are often widely dispersed, but one of the benefits of COVID is that we now have technologies that can link men across huge distances. And so perhaps that's also an opportunity to help to reach out to these particularly older men. So that's it from me. Thank you so much for listening. And I've put my email address there. So if anybody has any questions, please don't hesitate to contact me. Thank you.
Thank you so much, Lynn. Look, I thought that was fascinating. We spent a lot of time talking about the experience of care and perhaps the experience after caring ends, but just a perspective on the individual journey that we have into care and how one's personal history equips us or fails to equip us with skills that may have relevance to caring was really interesting. I'm going to move to our next speaker. Val is a fierce advocate for the rights of older Australians, a member of the Council of Elders and an active ambassador for the Older People's Advocacy Network, Dementia Australia and the Council on the Ageing. At 94 years old, she's currently studying a Bachelor of Dementia Care and has recently been awarded the Medal of the Order of Australia, where she's honoured for her services to people impacted by dementia. We're going to watch a short video, which Val has pre-recorded in conversation with Joanne Kershaw, the Sector Engagement Officer for the Carers Knowledge Exchange.
Thanks, Val. Val, I might start by asking you to introduce yourself, please.
Well, my name is Val. Sorry, my name is Val Phil. I'm 94 years old. I have been in the my aged care field for many years. Prior to my husband being diagnosed with Alzheimer's in 2006, two other members of my family, two older brothers-in-law, had been diagnosed with dementia, so I'd actually sort of seen it from the 1960s onwards, and that's how I was able to pick up the fact that my husband was developing Alzheimer's, because I saw the behavioural changes in both Johnny and Bert, right? So, but in 2006, Ian was diagnosed. I looked after him at home until 2010. When, for reasons other than dementia, he went into care for 3 years and passed away in 2013. During that period of time, I had become a dementia advocate, and then I became part of COTA, New South Wales, and then that expanded into OPAN's National Older Persons Reference Group, and subsequently the Council of Elders. So, you know, and I am still on those COTA, OPAN and the Council of Elders and Dementia Advocates. So it's been a busy time over the last few years, and particularly over the last, well, nearly 2 years. Will be 2 years in December, when I was appointed to the Council of Elders. You've got to keep your mind and your body active, and that's one way of doing that. Well, as an example, I suppose I'm an example. I'm busy all the time because I'm connected, you know, sort of through my connections with various things. But an example of that was on last Wednesday, I wasn't feeling up to do my monthly support group, which, as I say, I have been running actually since 2012. And I didn't feel like doing it, so I asked two of the ladies who have been coming for some time, if I sent the material up to them, would they run the meeting for me? And they did, but they ran it as a social meeting, not as a formal education social combination of both. You've got to keep your body active, as I said, And that's by, doing exercises, going for walks, anything like that that keeps your body active, and making sure if you need it, that you have physio. But apart from that, you need to keep your mind busy as well. People just think, oh, if I can walk around the block, I'm all right, But you've still got to think of this bit up here, which that needs enabling as much as the body. And there are things that you can do, apart from joining view clubs and that kind of thing, which gives you social activity as well as educational stuff. You can sort of take up line dancing, or any sort of dancing is fantastic, because not only are you exercising your mind when you have to learn the steps, you're also exercising your body as you do the steps. Learn a language, do something new, do something different, start to educate yourself online. There's a lot of stuff out there, particularly some from Carers New South Wales. But there are a lot of things that you can do just to keep yourself active. Don't become socially isolated.
So, Val, I'd love to ask you about, I know that you've been doing a lot of, you've been involved in a program, an intergenerational program. Can you tell us a little bit about that and how that helps build social connections? Well,
what it does is it builds empathy between the two generations. It's a program run by Greg Cronin, who is a leader of a particular group within the intergenerational area. He connects schools and nursing homes, right, and a few outside people. And the school chooses a topic for a 5th class, or now we've started up into secondary schools as well, for the day, and it's connected so that you've got the class in the classroom, and you've got a group of elderly people in a nursing home. There's a group in the nursing home, there's a group in the school, and there are a few outsiders. So we're all connected on Zoom, and the topic is chosen. It can be sort of something on, it's out of the curriculum, it can be talking about dance, or it can be geography, or it can be food, or it can be resilience, any of those things. They each group, the nursing home people and the class, are given a couple of days to prepare what they're going to say in that particular activity. And the people in the nursing home will say to you, the 2 best days in the week are the 2 days, one is the day before we go and talk to the children, or don't go and talk to them, but they're in the activities room at the nursing home. And the first one is preparation day, when we giggle and laugh about what we're going to say. And then the next best day is the day we're talking to the kids, right? And the children will say, oh, it's great, we love their stories and all the rest of it. And one little fellow once said, I haven't been to the headmaster's office since I started this group. He changed his whole approach to life, sort of thing. And they are so great. And there's this empathy between them. There's respect, they'll talk to the elderly people by name, and the elderly people will refer to them. But once they've been introduced, it's on a first name basis. And the kids develop such a connection to these people that when they go up into 6th class and they're not on the program anymore, or they may get back onto it when they go to secondary school, they can maintain that connection, and their families, and they go and visit them in the home.
Yeah, fantastic, Val.
But you'll laugh, because here is me sometimes at this time of the morning, 9:30, when the schools start with their thing and that connection's all set up, and halfway through the lesson, we'll stop because we need a break from that, and Greg will say, we'll play a game. So, we play Simon Says, I'm sitting up in bed sometimes playing Simon Says at that time of the morning. Or, Sorry. Something like that, you know, and it's quite good fun. One of those is exemplified in the resilience lesson that we did one morning when the children were asking, what do you do when you feel down or depressed, you know? And the people would say, oh, well, and when you were our age, if you felt like that, what would you do? And some of them were saying that, you know, they'd been through all this when they were at the war, right? So they talked about how they got on. But I've always been amazed at the answers to one of the children when they said, well, what do you do, to Joe, you know?
Yeah.
This little boy said, I stop and think how lucky I am.
Thank you, Val. Look, lots to take away from that, but personally, I would just highlight for me, what came across was just that value of anticipation of the caring role, seeing that it coming through the family, having previous experiences, and then being able in a range of ways to be proactive, to pursue, I think, things that would have worked for her across a range of physical, dancing, exercises, involvement in family support groups, intergenerational activities, self-education, lots and lots of things to draw upon in the discussion groups post this. I will, though, turn to our last panelist today. And Lauren McGrath is going to talk to us and introduce some important issues around children in hospital settings. So Lauren, you have the floor.
Thank you so much, Hugh. Firstly, hello everyone. My name's Lauren. I am the Consumer Experience Manager at the Children's Hospitals Network. Before I really get started today, I just wanted to take a moment to acknowledge the traditional owners and custodians of the many lands of which we're all meeting today. I recognise that as a virtual event, there's many of us on many different lands. I'm joining from the lands of the Guringai people of the Darug Nation, so that's up in northern Sydney. But what I'd really encourage you to do, if you don't know where you're joining from, take a moment to do a quick Google, because what I've found out since learning about the Guringai people is actually that in almost my backyard, there's just so much history right here, and the care and expertise that's got into the lands of which I now call home. So I just wanted to take a moment to recognise the care that has come before us and the care that we'll hopefully take into the future. So, as I said, I'm Lauren. I'm the Consumer Experience Manager at the Children's Hospitals Network. So I manage a really passionate team of 6 individuals who work to improve the experiences of parents, carers and patients who access what we call SCHN services. So in a nutshell, what that is these 6 services. So we've got 2 large hospitals, so Sydney Children's Hospital at Randwick and the Children's Hospital at Westmead. You may have heard of them both. We've also got the Children's Hospice, Bear Cottage, which is out in the Northern Beaches at Manly. We've got a research arm called Kids Research. And we also have a neonatal transport service, so NETS, which works to transport neonates and paediatrics, so young children, across the state as needed. In addition to that, we also have the Children's Court Clinic. So that is a service that's available to support the assessment of children through court processes. So just to give a bit of context to what those 6 services do, in the last financial year, there were more than 1 million occasions of service for non-admitted patients. So more than 90,000 ED admissions, more than 50,000 hospital admissions, 158,000 children and young people who interacted with our services. And really, when we look at that from a carer perspective, what that says to me is that, you know, we've had more than 100,000 interactions or potential interactions with parents and carers over the last year. So we have a big carer base that we do interact with and that we do support. As you can see on the right of the screen, so sorry, this is a really busy slide, but I just thought I'd try to do the whole overview in one. That's the elements that my team is responsible for across this network of services. So we're responsible for carer support programs. What do they look like? How do we support the parents and carers who have children receiving care from us? Equally, how do we engage with the parents and patients and families to really make sure that our services meet their needs, because that's what we're here for? management of the consumer feedback, so complaints, compliments, suggestions and observations, all those nuggets of wisdom that are shared with us. We really work to, one, both manage the individual issues, but also make sure that they are turned into gold and use what we can from that feedback to improve how we operate as an organisation. And finally, we also do the more strategic patient-reported measures. So that would be things like your surveys and your consistent surveying to understand how we're operating and how we're meeting the needs of people who access our care. But today, I thought we might take a little trip down memory lane and take you back to a time of, March 2020 when the world sort of changed. Some might even say it shut down. I know we shut our borders for a long, long time and things definitely changed. When I look at my career and my experience in New South Wales Health, it was definitely the first time in my career I've observed things like visitor restrictions being imposed, people meeting me at the front door to make sure that my temperature was correct and that I was wearing a mask before I walked into a care setting. If I was having a non-urgent appointment, it was more than likely cancelled. And equally, if my surgery wasn't considered urgent, it was also potentially cancelled. Health definitely kicked into disaster preparedness mode. And I guess the best way I can summarise that is that the unknown was well and truly upon everyone. And as you can see from this timeline I've sort of put up on the screen, the pink dots are sort of the milestones throughout the last couple of years, but really we had a long period of time of unknown where we were closing or restricting access, reducing the number of people accessing hospitals. And in a children's hospital setting, that meant limiting the support that was potentially available to carers as well, because acknowledging that in a paediatric setting, we have our patient, but we also have our parent or carer who's an essential part of our care team. So fast forward about 6 months from March 2020, not a lot had happened when you look at the COVID front. We hadn't experienced a great volume of COVID infections like we may have seen in hospitals overseas, such as Italy or New York. However, we were starting to observe that there are other impacts of these restrictions and the unknown, and the impact that that was having on both our staff, but also the parents and carers who were, part of our care team and part of that care journey. Many people were pondering, how could we make this better? How do we, improve what we're dealing with? How do we make it a more pleasant place to be? And so, they started doing things like handing out colouring books or encouraging people to practice mindfulness, introducing daily meditation sessions, all really important, but didn't really seem to be shifting the needle too far. So my team and I did a little brainstorm and we came up with a simple but different solution. We just thought, why don't we actually start to have conversations with people? A lot of our social connections throughout COVID were reduced or minimised, and definitely, you think of the terms such as social distancing that were implemented, they were almost discouraging us from communicating with one another. So our team said, why don't we break down that barrier and why don't we just have conversations with parents and carers who are in our services? And it actually became the underpinning strategy for how we managed and supported parent and carer experience throughout the COVID response. As you can see on the screen, we've got blue dots scattered throughout, and what we came up with was an initial snapshot. So a one-off event just to say, well, what is the parent and carer experience? How are they doing? What's working well? And what can we improve? And the first snapshot was really insightful. So that was November 2020, and it gave us all this data of what we could do differently. And we started to go about implementing some of those changes. But then come December, we had Northern Beaches locked down. So our first Christmas with COVID, and the hospital went into even stricter access controls to really try and mitigate the risk of the COVID spread, because it was spreading very fast. And being Christmas time, it's an important time for parents, families to come together, and children especially in hospital. And we had restrictions in place at New South Wales Health to say it was only one parent or carer who was able to be in the hospital at a time with their child. And we recognised that wasn't going to be good for wellbeing. So we adapted our strategy of asking families how they're doing and turned it into a daily round. So there are yellow circles, and each time we got into really strict COVID lockdowns, we implemented that strategy and started to dedicate people to speak with families and really build relationships and bring the social element back and the wellbeing element back to that hospital experience, which can be really, really challenging. So as I said, quick snapshot of what it is. It's simply a way for us to better understand how we can better support parents and carers in our services. It involves staff. So the snapshot involves staff attending 4 wards at each hospital. So we tried to get a good mix of carers in our hospital. So carers of patients with a medical condition, a surgical condition, oncology, or those who are in intensive care. And by inviting them into having a conversation, really, we were just trying to understand what's working and what's not. So we had a very, very high level framework of the conversation that we had, but would go in with 3 key questions. How are you doing? How are you doing really? What's working well for you? And what's one thing we could do to improve your experience? And as I said, we morphed these snapshots into a daily round when we needed to. And what it enabled us to do was actually be really quite responsive. So by asking parents how they're doing, we were able to actually identify when we needed to add in additional supports, or if we needed to make linkages. If it was someone didn't have access to food services, we were able to get those things. So by having that initial conversation, we're able to make sure that their immediate needs were met. But then equally, by asking what was working well, we're able to find out what we could do more of. You know, what are you finding useful so that we can replicate that and continue to use that and continue to build that wellbeing model. And then aside from that, the what we can improve or how can we improve question really gave us some simple solutions. And they weren't groundbreaking. It was get someone to have a look at the shower. I think it needs new grout. Easy fix. Upgrade the parent beds. They're quite uncomfortable. Not so easy, but we can get to it. It gave us things to work towards that actually had a big impact on the parent carer wellbeing of people who were in our hospital. And as I mentioned on the timeline picture you may have seen, we've now continued to do these snapshots because of the value that they do bring. So I guess to sort of wrap it up, what I'd say is my challenge to everyone who is here today is to lean in and start the conversation when you're thinking about carer wellbeing. When you're looking at how we can better carer wellbeing, I'd encourage you to just ask the question, because you never know how simple the answer might actually be.
Brilliant. Thanks, Lauren. Yeah, look, heaps to take away from that one. So much of the primary go-to with looking to provide assistance is technology-based, but just the ability to have conversations and ongoing repeated conversations to assess real needs, develop appropriate responses, and then actually just check in whether those responses actually solving the original problem. I could see the absolute value of the time that was spent there. Our workshop today drew upon the insights of 3 different panelists, and we really want to pair that with some follow-up group work with the aim of drawing out some collaborative ideas for new sort of research and service initiatives to improve the social connectedness of hidden, hard to reach and disadvantaged care groups, and in turn to enhance their wellbeing. All right, I think we're coming back from our break now. We have 3 breakout room questions, and for each of those 5 breakout rooms that we have, we are going to have a facilitator and a scribe to help us to work through those little starting questions that we have. So our admin team will now assign you to a breakout room. You're welcome to remain in the main room if you would not like to participate in this exercise, but we can still come back and we'll share the insights and thoughts that were covered in those sort of individual breakout rooms in about 25 minutes time. So you can see the questions there. How can we apply evidence and lived experience to improve carers' social connectedness. Second, if low social connectedness reduces wellbeing and low wellbeing reduces social connectedness, how then can we apply evidence and lived experience to break this cycle? And finally, what would customised support around social connectedness and wellbeing look like for specific groups of carers? So we've had a couple of examples that have been covered in the presentation today. Gender might be one issue, and we could also reflect on experience or class or any other dimension that you think is relevant. Okay, I do think we've now turned to 4:40, so I'm going to thank everyone. I'm going to hand you back over to Carol Mills from IPPG, who is going to wrap up the day for us and connect us with a concurrent session that's been running alongside ours this afternoon. So over to you, Carol. Thank you.
Thank you, Hugh, and thank you for a very capable management of that session. And again, really interesting feedback from the participants in the dialogue, and look forward to seeing some of that written up and getting into some of the detail as we follow up with this session. Before I do close, though, we have one more thing to do, as Hugh alluded to. We're going to cross for a session, brief session, with our compatriots who are working as part of the Research Incubator in Monash. They are a part of the Rail Research Centre, and Associate Professor Libby Callaway is going to give us an overview of the key learnings that came out of their parallel presentations and discussions before we close. Libby, can I hand over to you, please?
Thanks, Carol. What a really important and interesting discussion today. We did focus in on understanding hidden carers and carer diversity. We had 5 presenters who talked about some of the challenges in identifying carers, or them perhaps being comfortable to self-identify as a carer. There were really 5 key things that came out of our discussion, and they really resonated with some of the earlier presentations from today as well. The first one was how there will be some carers, both young carers as well as adult and older adult carers, who intersect with multiple systems. Now, that might be the education system, the mental health system, housing, the NDIS or other disability services or aged care systems. And how can we really build a workforce of future allied health professionals, of future service providers that understand and identify informal caregiving and how we can best support carers across those systems. The other discussion we had was the importance of peer support and how often identifying carers can be, and giving them information can be best done by and with other carers. We talked about the lived experience expertise that carers can bring into both research, but also service development and provision. We did have a discussion about the mental health impact of caregiving and the importance of acknowledging and supporting mental health and mental health outcomes of carers of all ages. We had a really impactful presentation on younger carers from our colleague at University of Melbourne, as well as Chinese mothers of children with disabilities and some of the mental health impacts experienced for those 2 groups. The other discussion we had was how we innovate and create flexible service models that are going to respond to the goals and needs of caregivers. We heard from our colleagues at the University of Western Australia about a phone-based nurse-led service that's really impacting sustaining caregiving through Western Australia. We heard about a new carers clinic being run out of the Rail Research Centre at Monash University and the National Centre for Healthy Ageing there. And the feedback in co-design processes on those was that sometimes a telephone is a lot easier and a lot more accessible than physically visiting or even using digital platforms like video conferencing to support caregivers. And the importance, Carers Victoria was really talking to us about the importance of having multiple ways of how we reach out and connect with carers. So they were the key messages out of our session. It was such a great session, and I thank you for the opportunity for Rail to support this great carer knowledge exchange.
Thank you so much, Libby. I mean, really interesting parallels with our discussion, and let's hope that we can get them together and really build a strong program of practice-based, impact-driven research that can really make a difference for carers. So that brings us to the end of the session and the end of the day. I'd like to, on behalf of Carers New South Wales, my organisation, IPPG, and the Carer Knowledge Exchange team, the Rehabilitation Ageing Independent Living Research Centre, and everyone else who has contributed today, a sincere thank you to all our speakers, to our breakout room facilitators, to everyone who's participated and contributed this afternoon. These sessions have been designed to help draw out collaborative ideas for new research and practice initiatives, to help improve service access and social connectedness, particularly for hidden, hard to reach and disadvantaged carers groups. In turn, we all aim to improve the health and wellbeing of carers. We couldn't have done this without your participation, so thank you again. We invite you to tomorrow's sessions of the Research Incubator, and we will continue to exchange ideas through our platforms, our future events, and for the very many opportunities that we are trying to develop up that are linked to in the chat. We've now come to the end of our formal part of the session. We'll be finishing with a guided meditation hosted by Prue Granger, who, in addition to being the Carer Knowledge Exchange carer in residence, is also a yoga teacher. Research and practice show us we all benefit from these mindful activities, and the exchange is also actively looking for creative and effective ways to foster improved carer wellbeing and health, including things such as guided meditation. So thank you again. This is the end of my period, but I'll hand you over to Prue and hope to see some of you tomorrow. Thank you.
Thank you, Carol. Hi, as Carol said, my name is Prudence and I am the carer in residence for the Carer Knowledge Exchange. And my role is to bring lived experience to the forefront of this project. As Carol said, aside from my work with the Carer Knowledge Exchange, I am a yoga teacher. And I found in my own care journey, having this support, this tool of meditation to create a little bit of calm in the storm of care has been really, really supportive. And today you've absorbed a lot of information. It's been a very long session if you've been here from the beginning of the day. And with a lot of information like that, sometimes it can create a bit of overwhelm in the mind. So the intention for this afternoon's meditation is to offer yourself a little bit of space to digest and process what you've taken in. So before checking in with the mind, let's check in with the body. Notice how you are seated currently. If you're seated on a chair, are your feet flat on the earth or are your legs crossed? Can you feel both of your sit bones, so the pointy part of your anatomy, pressing into whatever it is beneath you? And so doing that to develop a groundedness in your physical body. And if it's comfortable for you, I invite you to close down your eyes, to turn inwards for this moment. And then feel as if there's a piece of string attached right to the crown, the tip of your head. It's gently pulling you to the ceiling to create space in your vertebrae. Once you feel that space developing through the center of your body, perhaps notice if you're leaning anywhere in particular, forward, to the left, to the right. How can you bring yourself into the midline of your own body? And to create this stacking feeling of head above shoulders, shoulders above waist, waist above hips. From the body, come to witness your breath. Notice how the inhale expands to fill space in your body. And the exhale softens, it lets go of the air you've just consumed to make space for what is to come. And can you deepen this breath just 5% more. So as you next inhale, perhaps expanding into a new pocket of your body to take in another sip of air. As you exhale, take your time, feel the air exiting your nostrils. Inhale, take up more space. Exhale, take up more time. And then if the mind continues to wander to events of the day, or if you notice the mind ticking, thinking of how you can apply the knowledge you have consumed, that's totally okay, that's normal, but I encourage you to gently draw it back to the present moment, to notice your own being. And sometimes steadying your breath can then steady your thought processes to create more clarity of how to move forward. And it is said that in this modern world, in one day, you consume as much information as you would have consumed in your whole lifetime 100 years ago. It's the amount of data, information that you are receiving and processing is quite a lot, which means it is harder than ever to find steadiness. And so don't become frustrated by the mind merely doing what the mind was designed to do. Instead, compassionately draw your attention back to the breath. Feel the inhale, swell the body. The exhale lets go. And as you exhale, perhaps you use that exhalation to let go of some lingering tension. If your shoulders are tight, or you're crinkling your nose, or maybe your toes, direct your exhalation to those spaces to feel a release. Often physical tension is a tangible manifestation of what is occurring in the mind. If you release the body, it triggers a release of the mind too. And start to witness these phenomena, the shifts that are occurring with each and every breath. And the idea here is not to completely fix all of your problems in one quick meditation, but to perhaps create 5% more space in your body or your mind, and so that you can approach what is next with more ease or receptivity. And so I'll leave you without my dialogue to take 10 full breaths and to notice when the mind distracts you. Can you gently coax it back to your focal point, to your anchor, the experience of breath expanding and contracting within you? The mind likes to complicate things, and this practice is simple on purpose to bring you back into the ease of simplicity. And as you complete your next exhale, come back to an intuitive breath rhythm. Maybe notice what has shifted. Again, all that needs to shift is maybe 5% more ease in the body, 5% more space in the mind. It does not need to be a profound or overwhelming feeling, just enough to create a ripple effect in your day-to-day life. If you struggle to focus, that's okay. And that is quite normal. And be kind to yourself in this process. And bring your hands together, start to gently rub the palms together to feel a little bit of friction, a little bit of warmth rising beneath your palms. And as that heat develops, notice the sensation, the buzzing, the life beneath your own fingertips. And then place your hands just in front of your eyes, creating a little cup over your eyes. Perhaps you feel that warmth radiating towards your face. And gently blink your eyes open. Notice the unique lines of your palms. And to bring yourself back into the world around you. And then open your hands slowly away from your eyes to absorb the light of the world, of your screen. Nice little integration back in, not too quick. Thank you. If you have any questions, I'll remain online for another minute or so and you can pop them in the chat. Otherwise, thank you so much for participating. And I hope to see you tomorrow for our final session of the incubator.